All year round, Frontier Home Products and Design has what you need to make your home comfortable and beautiful. Relax on a new timber tech deck designed by Frontier's experts. A new fireplace from Frontier Home Products Fireplace Gallery adds warmth and serenity to any home. Beauty and versatility at Frontier Home Products and Design Center, 4213 Peachtree East 5th next to the Bayfront Highway.
Frontier Home Products and Design Center. Discover a new frontier.
PA contractor number PA039007.
Get paid to drive. Start a new career behind the wheel at the EMTA. If you are looking for a high-paying and rewarding career with full benefits and paid training, stop by or apply online today with the EMTA. Plus, EMTA riders can now enjoy free Wi-Fi on new, clean, and environmentally friendly buses to travel all over Erie County. Visit ridethee.com for more information.
Get on board EMTA. Get on board EMTA. Get on board.
Welcome to TalkErie.com's Joel Natale Show, Erie, Pennsylvania's daily podcast. Every day, we tackle the biggest issues that the Erie PA region faces. Stay informed and involved as we advance the narrative of Erie. Now, here's Joel Natale.
We have a regular conversation with Dr. Fernando Melaragno. He is an endocrinologist and a diabetes specialist with LECOM Health. Doc, good to see you. Appreciate it.
Hey, thank you for having me again. Yes, November came and went. There was that little election that took place that might have, taken up some.
We were a little distracted,
Yeah, I could see that. We all were. But that is behind us now. No, I'm happy to be a part of the show again, December or otherwise. And from the comfort of my home, when I stepped out of my office today and that wind hit me on Upper Peach, I could only imagine how cold it is down at your studio. So I said, you know what? I think from the comfort of my home office today.
Yeah, and there's really no place to park, so you're in the safest place you need to be. We're gonna take phone calls too. We'll be able to share that with Dr. Melaragno at 814-679-1080, and I'll need you on that too. So. All right.
Yeah,
all right. Let's get started here with, defining terms. Okay.
Sure.
And so when we talk about diabetes awareness, there's two different things, and they're almost, well, you tell me the difference between type 1 and type 2, and aren't they really two different syndromes?
So absolutely, it's important to start from the basics, and what's type 1, what's type 2. They're very different. They're very, very different. Type 1 is far less common, and that is associated with a lack of insulin. So insulin, we know, is a hormone in our body. It's produced by our pancreas, and what does it do? It helps. It takes glucose from our bloodstream and allows it to enter the cells that need it for energy. That's what insulin does. Type 1 diabetes is a condition where those cells of the pancreas that make insulin, due to genetics, they are destroyed and they don't work any longer, and a person requires insulin in order to stay alive. Often diagnosed at early age, but can sometimes occur later in life. So that's type 1, younger population, usually insulin dependent, must have insulin. Type 2 is far and away more prevalent in our country and in the world. And that is more genetic. If your mom and dad are type 2s, a person's more likely to be a type 2. And it has a direct connection to obesity. And that's related to insulin resistance. So it's the insulin is made just fine. The pancreas is not the problem, but due to obesity and a lot of other factors that you talk further about, the body the blood sugars just keep climbing and climbing in the blood, and there isn't quite enough insulin. So a person's insulin levels actually rise. And a type 2 diabetic, after trying different pills and different medications along the way, may need additional insulin to control their sugars.
And this was a rare? Those type 2 diabetes rare? Let's say, at the time that they discovered penicillin, for example, were people dying of type 2 diabetes like that?
Well,
in the last 70, 80 years?
That's a somewhat challenging question because it's hard to say if the diagnoses and the if they were caught, right? But in general, the prevalence of type 2 diabetes is markedly elevated. It climbs every year, and it just parallels the obesity epidemic. So, and many years ago, when people were not as heavy as they are today, yes, there were a lot less diseases that were prevalent, either from medicine not being as robust as it is now, and maybe diagnoses weren't made, properly. But as we continue to progress with our obesity epidemic, all diseases are increasing in prevalence.
That really brings me to what I'd like to spend some time on here before the break, and that is the obesity connection and what that's about to all of these other syndromes that are happening, all these other maladies that people are dealing with. And I think is this correct to say it's some kind of a metabolic syndrome? There are metabolic syndromes that are connected to obesity. Is that accurate? And can you explain that through for me?
Right. So there is a term, cardiometabolic syndrome. Cardiometabolic syndrome is a term. It's been around for a number of years, somewhat roughly defined during its origins. There was an obvious connection with this group of conditions that seemed to interplay and interrelate to each other, and they called it cardiometabolic syndrome. It was people that were obese, that had known insulin resistance, sort of that type 2 diabetes patient that we talked about, that their insulin resistance, increased inflammatory markers, increased obesity, if I didn't say that already.
Yeah.
And poor cholesterol, higher levels of the bad cholesterol, lower levels of the good cholesterol. And just this constellation of these things, which would have these patients have an increased risk of morbidity and mortality, from cardiac events to even stroke events as well.
You said a lot there, so I want to break it down, because you're basically saying that one kind of condition of just carrying too much weight, or is there such a thing as the wrong type of weight? I guess. I mean, can you be?
Well,
I guess you could be big and thin though, or.
So it does come down to when they say that obesity increases the risk of cardiometabolic syndrome, they are defining a BMI of over 30 with an increased waist circumference, so increased central adiposity, so adipose tissue is just another name for fat cells. So we'll kind of interplay those, so fat cells, adipose tissue. There's actually good fats and bad fats. There's brown fat, white fat. Fat is not just a storage place for energy, if you will. It isn't just a depot where excess food is sort of stored. It's bioactive. It's biochemically active. It's hormonally active. It is doing things. It is participating in this whole milieu of hormone balance that we're talking about. There's inflammatory markers. Increased adipose tissue produces its own inflammation, which is one of the components of the cardiometabolic syndrome. And then there was a question of visceral fat versus more superficial fat.
Yeah.
Meaning the fat that's around your organs compared to the fat that's closer to your skin. And at first we really strongly kind of blamed the visceral fat, but we really realized that both of them are bad. So obesity is one of the things we focus on kind of maybe the most with type 2 diabetes, but we just have to realize there's an interplay between all these things we're talking about. Adipose tissue even plays a role in our cholesterol, right? We can probably appreciate that. We think fat, we think of cholesterol, but it even plays a role in some of the communications between our good cholesterols or bad cholesterols, and how that interplays with the liver, so all basically all the organ systems are involved with everything we're talking about.
I'm like blown away. I had no idea all that was coming to get. I mean, you hear about the things about your omentum, right? Which is, I don't know, is that the fat that's close to
That is sort of it's an apron-like organ that kind of drapes your organs. That's with the omentum, and it's there to cushion your organs. And there's and there's fat involved with this apron-like tissue, and then yes, that can become excess fat. As fat is stored wherever it can be stored, it goes up everywhere. But then we're talking about fat even around around the heart, around these organs that really should not be getting excess. It's not a good place to store your excess fat, but it goes everywhere.
Before we go to the break, I also want to ask about. Again, we've been talking about obesity. We will talk some more about that. But there are other kind of practices that exasperate what you're calling this cardiac metabolic system. Where does smoking play into this? Where does drinking play into this? And some of the other things that I've heard that don't seem to be great for you.
Sure, we can certainly talk about that. Did you say before the break or after the break?
Let's do the smoking right now.
Oh, sure. So so think of the pro-inflammation, the inflammation that occurs. What does that mean exactly? There's certain inflammatory markers, cytokines, different inflammation markers that are typically there to deal with a problem. There's an injury, there's an infection, there's a virus, and we know our immune system goes and attacks those things. But during those things, and these inflammatory markers rise too, and they help kind of combat the problem, try to deal with that situation. But just having these pro-inflammatory states of obesity and these other markers that we're talking about, insulin resistance, obesity, those will also increase your inflammatory markers. And then inflammation can cause kind of more trouble, sometimes, more trouble than it should, right? We know a fever is something that's supposed to help us kind of kill the bacteria, right? But it can also damage us. It's like friendly fire. So when these inflammatory markers skyrocket, it can cause damage to good tissue, and just like cigarette smoking can do. So one of the biggest things cigarettes cause, one of the biggest sort of forms of damage is how it works and how it causes inflammation on our small blood vessels. So it's our blood vessels that are damaged that ultimately will result in a blockage and a stroke, for example, or a blockage and a heart attack. High glucose, high sugar has a very similar effect, because it's not unlike, you can almost think of those crystals of sugar almost like tiny shards of glass flying through your bloodstream, because that's kind of what's happening. That's why the smallest blood vessels, the eyes, the kidneys, the feet, our diabetics that are listening know that those are the areas of greatest concern, right? Poorly controlled diabetes is a leading cause of blindness in our country, the leading cause of kidney failure in our country, leading cause of amputations in our country. So it's those small blood vessels in the eyes and the kidneys and the tips of your toes, the nerves that are serviced by the smallest of blood vessels. When those blood vessels are damaged by high sugars, those nerves are damaged, and then you have the neuropathy, the nerve damage of the eyes, kidneys.
So are you saying that smoking and diabetes is like a double whammy for the inflammation on the small blood vessels?
It absolutely is. I started a patient on a nicotine patch just today. Their family doctor didn't get to it or some such thing. She didn't bring it up. However, and I'm dealing with her sugars and her cholesterol's, or not her cholesterol, her A1C was actually excellent, and she's doing well on the regimen we have her on. So I didn't need to spend much more time talking about that, but she hasn't quit smoking yet. And I'm like, you really need to. And so I spent the rest of the visit talking about that, convincing her to start her nicotine patch because she was ready. So yeah, that just happened hours ago.
We've been talking a lot about obesity, Doc. Here's the NIH saying nearly 1 in 3 adults, that's 30.7%, are overweight. And this is from 2018 data. I think it's up to 75% now have one of these maladies. More than 2 in 5 have obesity. About 1 in 11 adults have severe obesity. And the whole idea of the BMI. And of 40 and above is severe obesity. Why are we? Why is this such a rampant thing these days?
Yeah, no, I think officially about 40.2% of American adults are obese or overweight, currently.
Wow.
With an elevated BMI, the body mass index, just related to your fat proportion or adipose tissue, related to the rest of your size. And why is that's a good question. At once it was thought to be related to, so sort of any civilization that comes into excess stability with their finances, agriculture, resources, then they have an ability to splurge in life a little bit, and then you see these cultures become more obese as they have more leisure time and more maybe more resources. But that doesn't totally play in our culture because we were doing quite well many years ago, and we were relatively healthy. You'll see these shots of black and white photos of America, and everyone's thin. Everyone looks pretty darn healthy, and so
Even in the
what's
70s, like,
right. Well, the 70s is when things started happening. They started pulling fat out of food. So, the late 60s, early 70s, even into the 80s, we might remember this fat-free phenomenon, which was arguably one of the very worst things that could have occurred. And it's been proven that the studies that were behind that movement were flawed. Not only flawed, but had pretty corrupt origins. So when that was done, what had to be done? They had to sort of substitute. So then you're getting things like margarine, canola oil, just remarkably unsafe, unhealthy types of products. What's a patient to eat or a person to eat if they can't eat fat foods, and they're eating more carbohydrate type foods? If they're staying away from maybe the meats and cheeses, now they're eating more breads and pastas or some such things. And I mean, to take fat out of milk, that doesn't make any sense. You created something that isn't milk anymore, or cheese, fat-free cheese, fat-free milk. It's sort of nonsense. You've just created something different. You should barely call it cheese anymore. You've just taken out a sort of a key component, and you've substituted these other things. When you read the label, you're reading these names of chemicals and things that you can't even pronounce, right? That's what they say about our ingredients today. And our RFK Jr. is talking about this, and not to be political. Well, I don't know. We're all political, right?
yeah, we have some kind of politics here and there, yeah.
Yeah. So, but the reality is, he's going to be playing a role in health in our country, and the reality is we're not on a good path. We haven't been on a good path. There's no denying that. There's no arguing that we have not been on a good path, and we need some changes. We need a different perspective, and I think that's what we're going to get with RFK Jr. And some may say he's radical or these different perspectives, but we need some pretty dramatic changes. Things, like I said, things are not on the right path. We need to change gears. So
can I ask you a question? Again,
yeah.
It may be this is more of a societal observation than anything, but we really raise to the top beauty and thinness in our culture, right? I mean, you think about there's very few athletes, and there's very few musicians, movie stars that are plump and significantly obese and looking out of shape. I mean, we love the muscular, MMA fighters and things like that. How come that hasn't translated in the rank and file citizenry of saying, hey, I want to be like Josh Allen of the Bills, and be strong and fit and trim, or
it's very hard to do that. It's because it's very difficult, right? For the average person, it's not very easy to get to that level of physique, right? So it takes money. Eating healthy in this country is expensive. And it takes time, and time is money as well. So some of our most precious resources, time and money, is what it would take to achieve, a higher physique at that tier that you're sort of describing, the elite, athletes, etc. But the rest of us, every day we're going through our day, we're eating what we're eating, we're doing the level of physical activity that we're able to do. I think it is a very popular thing. You look at all these YouTubers and social influencers and these things. Most of these people meet what some would classify as attractive. So people they're doing it. People are emulating those people. But why has it not become standard? That was your question. Well, I think because of how challenging it truly is, how costly it is to eat healthy, and exercise is part of it, but diet is a far greater part of it. When I have patients that need to, lose some weight, they need to focus on their diabetes. We talk mostly about, well, the right medications, because, ultimately, as a physician, what can I do? I can educate and I can prescribe, right? That's about it, right? And then surgeons can cut. That's about all we can offer for the most part. So I spend a lot of time educating my patients, face to face, and then providing literature for them to take home, and then prescribing the right medications after we've discussed all the different options and choices and come up with the right plan. So it takes a lot, I guess, is what I'm saying. But I don't focus on exercise. We talk about it, but if I had to depend on exercise, it would be really difficult to get our patients to where they need to get to regarding their A1Cs, their cardiovascular risk, and their weight ultimately.
But you will say that the exercise will bring you to higher good cholesterol and
100%. 100%. Yeah. No, 100%. But it's very difficult for most people to be able to exercise to that level,
right,
to get to make that much of a difference, due to their bad knee, their bad back, the list goes on. No, they don't have any money for the gym. They don't have any money for the equipment, for example. Although those things aren't really needed, gravity and your own body weight, a lot of exercise to be had. Walk around the block, but the patient, maybe they can't walk. So that part of it is a challenge. The part of it is a challenge.
Quickfill gasoline is made right here in America. United Refining Company, who operates Quickfill, refines its gasoline from North American crude oil in Warren, Pennsylvania. When you buy United Refining Company gasoline at Quickfill, you keep jobs and businesses in America, and you keep American families strong. You don't need to send your money overseas when you buy gasoline. Buy American-made gasoline at Quickfill. Quickfill, driving America.
From baggage claim to pajamas in 10 minutes. Erie International Airport. Fly with ERI.com.
Fly Erie International Airport to Charlotte on American Airlines, your nonstop gateway to the world. Also, we have Breeze Airways flying nonstop to Orlando and Tampa, Florida. A great low-cost carrier providing excellent service to the regional community. Fly Erie International for your travel needs.
Fly with ERI.com.
I'm interested in the workflow because, we talk a lot about mental health here, right? And, there's a specific, when you're getting your annual checkup, you're supposed, the PCP, the primary care physician, is supposed to look up from the chart and look into the patient's eyes and ask a couple questions, for a mental health evaluation. Obviously, for when you're doing the weight and the blood pressure, those stats, those vitals will tell you, okay, this person is 5'8", but he's over 200 and some. He's obviously got a BMI that's in the obese range. So those numbers are screaming out at you. What happens from the primary care level to go to an endocrinologist specialist? How does that workflow go?
Yeah. So traditionally, years back, when a family practitioner had a diabetic that was on one oral pill, maybe a second pill, a third pill, maybe the once a day long acting insulin was started. They're still not a goal, and now they're thinking about adding mealtime insulin for our type 2 diabetic. Wow. And that's around the time that they might say, you know what, time to go see a specialist. Or maybe anytime when a patient is just maybe the communication has broken down. They're not able to see eye to eye, and it's just visit after visit. nothing's changing, and they realize another perspective is needed. Another relationship needs to be established. So I see all kinds. I see patients that are just, wildly elevated A1Cs, and they need a really fresh start, or somebody in the middle that just needs a little more help because they're starting another regimen that maybe the primary provider wasn't that comfortable. And there's newer agents. There's newer agents all the time. Same thing. Maybe they're not as comfortable with those agents, so they send them to me. Those are some of the examples.
Talk about, is it easy for folks, because the obesity and now the type 2 is so widespread, is it kind of easy for society or even or patients or families to kind of take this at stride as kind of part and parcel of just living in mid 2020s America? I feel like we don't hear about the people that have 8s and 9s A1Cs. You know what I mean?
Yeah. It's unfortunate that, the norm, that needle, however you want to put it, has allowed for an unhealthy, weight to be sort of average, right? So, average should be in the middle, and it should be maybe, somewhere, healthy-ish, let's just say. And then there's the outliers, right? The super healthy, fit or whatever. And then there's, the obese, the unhealthy patients, people that have a lot of health issues. Unfortunately, average is moving towards the wrong side of that. And, when it just became more and more. Look at the sort of the jumbo size of your popcorn or whatever, your beverage at McDonald's. We shouldn't be frequenting our fast foods too often, but it was just the way it all changed. The size of these things. You go to other countries, and those sizes would be obnoxious. You go to Europe, you wouldn't see such a thing. A portion that large, and in fact, you do see, for the most part, healthier, some thinner populations in those cultures that have a different perspective on food, right? It is more the Mediterranean diet, right? So if we're talking about the Mediterranean, those parts of Europe, that's the number one diet every year. It sort of wins the award of best diet, quote unquote. And I don't mean a diet as a fad, as something like a all salary diet that you do for a week for a cleansing. Diet is just what you eat every day. That's what your diet is. And the Mediterranean diet is leaner meats, higher vegetables, the right kinds of oils, olive oil, a certain amount of fruit. It might even have a glass of wine as part of it. And food is part of the culture and part of the experience of family time, interacting with people. Now we're talking about blue zones, which is a whole nother sort of conversation.
Right, sure.
Where certain parts of the world where people live to be 100. These were coined blue zones, and those were also the commonalities. A Mediterranean type of diet, an emphasis on family time, an emphasis on our elderly, walking, being outdoors a certain amount of time every day, and a glass of red wine was part of most of those cultures as well. So. We don't really eat that way, right? We don't just have one glass of red wine in this country. We'll have four, and and we'll have portions that are just inappropriate, and these types of things. We do not go out and take a walk after every meal, when many cultures do. That's part of the experience. You just ate a big meal, you enjoyed it. Well, you know what? Walk some of it off. But we don't. We go right to the couch. We're watching TV and movies, and then we're snacking some more. Because we're watching the commercials we're getting inundated about chips and all these things. We walk over to the kitchen. Now, we think it's a free time. We almost think it's some sort of like granted time where we're allowed to just snack between dinner and bedtime, where that's when the obesity epidemic is happening. It is between dinner and bedtime. That is the witching hour for most of us. And then we're watching the commercials, which maybe they shouldn't be allowed to advertise such unhealthy treats during those hours. But that's not regulated. The powers that be don't necessarily have our best interests at heart, and we're going to be hearing more about that with the current administration, to be quite frank.
Yeah. Let's talk. I want to mention something that you just said. You were talking about obesity and being unhealthy. And I think culturally right now we're in a moment that that we're having a conversation that people are even like, they're thinking about alternative facts that you could be obese and healthy, and I'm not sure that's going over very well.
I think that was quite a fad, maybe 3 years ago, maybe even more, right? Where you had these cover girls, these on magazines and things, which were beautiful people, I'm sure, and but yes, at an unhealthy weight, and there's no kind of mincing the words there. Those levels of adipose tissue in a body is not healthy. Can some people be heavy and healthy? And yeah, they can, but maybe they're genetically predisposed to just simply carry some of that weight and not have not all the consequences, but some of the consequences. I can tell you their joints aren't happy about carrying that carriage. So, but are they still beautiful and deserve it? Yeah, sure, of course. That it isn't, beauty. Beauty is well, the eye of the beholder, right? But just to say that they're perfectly healthy, there's nothing wrong with those situations. Well, that's dangerous. That is not safe for our young people, right? But then the other end of the spectrum, where there's such emphasis on thinness and beauty, and you have young people using beauty products when they have, perfect skin. They're 7, and I'm like, right. I don't quite understand. There's no better skin than that. That's it. So I don't quite understand that. But
that we've reached a level of decadence in this society when young girls feel like they need to go get skincare treatment.
That's a whole nother conversation. That is a whole other thing.
Let's move on to the current drug situation, because I think this and you call it the GLP-1s, and there's other ones,
Sure.
but this is kind of broken through. We talked about this last year. About these miracle drugs, but we have to look at them seriously, because there are a lot of side effects. Yet there's some miraculous things that go on here. They're saying that it could stop addiction. There's stuff going on in your brain. So can you explain what the drugs do and how they help diabetics?
Absolutely. So, the one that you mentioned, Ozempic, that's been the probably has had the most airwave time.
It's basically half of the economy of Denmark is Novo Nordisk, right?
I mean, that's correct. I think it might be more than half at this point. Yeah. So that's semaglutide is the name of the molecule, and GLP-1 is the name of the class, which has been around for over 25 years. Byetta and Bydureon was the first on the market for a weekly injection. These are injections. At first, they were daily injections, not insulin, but just a medicine that's being delivered through a needle. First, they were dailies. Then we were able to come up with weekly, which is obviously far more convenient, one shot a week. And then a lot of other classes have come along, and there's several to speak of. What's great about them? When I ask a patient to consider starting one of these medications, what I do remind them is that this GLP-1 and a newer class GLP-GIP these are simply these are hormones in our bodies. These are mimicking. They're called mimetics. They imitate hormones that are already in our body. Some of the things that are sort of broken in our metabolism, to sort of simplify things. Why are you obese when you eat the same amount of food as your spouse or your sister? Well, because your wiring is a little different, if you will, but it's your hormonal balance. All those things we kind of talked about with the cardiometabolic syndrome, what the fat cells are doing, how much inflammatory markers there are. Genetically, how you're just predisposed to process that meal, to how the body decides to store it, what your cholesterol is doing. All these things lead to obesity, lead to all these disease processes. So what makes one person different than the other? It's these hormones. When a person describes my metabolism, I have a slow metabolism, I have a fast metabolism. What does that really mean? Well, not much to the average person, but it's the hormones that are doing the magic behind the scenes that turns your meal into energy and into the cells of your body. These are some of the hormones, just some of the hormones that we know play a major role. So when I ask a patient to consider one of these injections, I just kind of try to remind them that it's not a crutch, it's not a fad, it's not a stimulant, it's not a weight loss medication. It is simply replacing or supplementing the hormones that are in your body that are kind of broken, if you will, just not working as well as they should. We're giving some more back to you, and lo and behold, you're having amazing results. We didn't invent the molecule. The good creator above or whomever you might believe in, your body's using this molecule that already exists. So, and yes, we're finding out that it has the ways that it works on many organs of your body, but it's one of the hormones that tells your brain when you're full, right? So you've eaten a meal, oh, you're full. Well, how do you know you're full? Are you touching your belly with your hands and your brain is aware that your belly's large? No, you have a feeling of fullness. What does that? Well, hormones like this that go from your gut to your brain and tell you you're full. And if that's not working as well as it should, a person may be prone to overeating. So this is a molecule that can help tell you when you're full, and it hits some of the same markers or triggers in the brain that have connections with addictions. So yes, it's being actively studied with addictions as well, and just yeah, it's going in a lot of directions. Pretty soon, they'll be indicated as a primary cardiovascular preventative indicator, where you take this medication to reduce your risk of a cardiac event, regardless of your diabetes status.
Wow. I didn't realize
So,
it was going into that part of the
yeah,
system. Wow.
absolutely, absolutely. And there's more coming down the road. So, it's a remarkable time as far as I'm concerned, to be an endocrinologist because I have so many wonderful, as I put it, tools in my toolbox to do my craft. And these are largely just remarkably considered effective. And then the safety is an issue.
Hmm.
So, kind of have to acknowledge that. A patient's going to say, well, is it safe? Is it going to interact with my other medications? The answer is no to that. It's like I said, it's mimicking a molecule in your body. But, too much of a good thing is what? It's a bad thing, you might say. So even though it's mimicking something, is it still safe to just have on board? All studies over a quarter of a century at this point are pointing to yes, they're safe. But there's a couple warnings that you'll hear on the commercials and things, right? So medullary thyroid cancer was seen in rodent studies only, and not in people. There hasn't been cases seen in people, and that was at mega doses. And even though a rodent is a mammal, as we are, we're still not the exact same sort of
Right.
entity. So there doesn't mean there has to be any kind of cross reaction, and there doesn't seem to be. Pancreatitis, inflammation of the pancreas, is one of the risk factors. Typically, with somebody who's already had it before, and that's been fortunately a very very rare occurrence. Gastroparesis, delayed gastric emptying. That's just something the molecule does. It slows the transit of food through your gut, so it's more efficiently absorbed. But if your gut's already a little bit moving a little too slow, maybe from diabetic damage, or if you challenge it with a very large meal, you're going to feel nauseous. Those
There's
patients that,
no doubt.
yeah,
I mean, yeah, I mean, you're prone to, it just won't be gross for a second. You're prone to vomiting. You might be prone to, all kinds
you
of
might have
diarrhea or
more of
whatever.
that.
You're gonna have
Yeah,
more.
yeah. If you have some of those symptoms,
I'm running out of time. I want to
yeah,
cut to
yeah.
as you look at the next 12 to 36 months, what is on the horizon? Because again, the new data is there is such a need here, and you mentioned RFK Jr., you mentioned Bobby Kennedy. I mean, he says if we took that 1,000 a month that it costs the insurance companies to pay for Ozempic and put everybody with a gym membership and maybe $200 a month of produce, we could get the same impact or for half the price or whatever. I don't know if you heard that, but I mean, it's about. I mean, all the things are there. It's just that people don't avail themselves of this, whereas this is the Ozempic and the drugs are changing people's brains a little bit.
Yeah, right. No, I certainly heard his perspective on GLP-1s and all of this, and I think I think he's looking at this as in a lot of ways that it sort of is a crutch. Like,
Yeah.
well, you don't need that necessarily if we just make these good changes. Eating healthy is what we're supposed to be doing. This human body of ours would be healthier if we ate better foods, healthier foods, and if we were more active than what the average American is. So he's kind of like cutting it off at the pass. Like you won't need that if you won't need that medication if we could fix these things. And I hope we're in a position where we are going to start fixing some of these things, improving our nutrition in our country. But
I always look at it this way: if Oprah Winfrey is getting results from an Ozempic type of drug, and she hasn't admitted to it yet, but she's obviously seen some results recently, and she's admitted to some kind of medical intervention. I mean, she has access to any physical trainer, any diet, whatever, but she's needed. This is the thing that's pushed her to success, and so if she needs, if she needs the crutch, we all do,
Right. Exactly. She had the resources. She could hire a personal trainer and chef, all day, every day, which, some people do. But she did, in fact, admit to being on, I believe it was Ozempic. I think it was last year. She had to step down from her Weight Watchers board membership because you're not supposed to be on those medications. Right. So, just giving a person a gym membership isn't gonna make them go. Right. Yeah. So I have countless patients and even I'm even guilty of donating to gyms over the years where, so it just needs to,
I love that. Donating the gyms. I like that. I've got like 60 seconds. First, one more quick question and then a final thought. AI, do you see AI playing any role in fighting diabetes?
Well, AI is going to touch everything in a lot of ways. Right? It really will. So I can only hope that it providing quicker information to those seeking it out, maybe accurate, effective information to those seeking it out, be it learning about a medication, learning about nutrition, learning about fitness. Sure, it's gonna help people. Yeah, absolutely.
Yeah, I mean, if you could ask Siri, hey, what's this apple going to do to my glucose level? I mean, that'd be pretty amazing,
Oh, absolutely. Well, I had patient. So there's apps that could help you track your nutrition for diabetics. A patient yesterday was telling me she just took a picture of her plate and it told her exactly what was in it, the calorie count, the carb count, everything. So she can track her regimen that way, and it is becoming incredibly accurate, and it's just only going to continue getting better. So
could we make Erie healthy again through focusing on obesity?
I hope so. I mean, this cardiometabolic syndrome that we've been talking about, it's an opportunity to sort of offer some preventative medicine. So when we can screen for a lot of the numbers that the blood pressure, the inflammatory markers, all those things, you can kind of put that into a formula and see what a person's risk of diabetes. Because we didn't talk much about pre-diabetes, and I'm sure a lot of our listeners have been told they have pre-diabetes. That's your sugars are high, they're not normal, they're not in the diabetic range, but you're at risk. I'm hopeful to offer that service to the community here soon, where we can really risk stratify some patients and get a personalized sort of treatment plan to prevent them from developing type 2 diabetes and the other complications that could follow.
Always a pleasure, Dr. Fernando Melaragno. He is the endocrinologist from LECOM Health, and we appreciate you sharing your expertise. It's like an hour with the doc. And really, we need to keep moving our society and our community forward. Appreciate the time.
I enjoyed every time, Joel, and I'm happy to help. So, thank you for having me.
You've been listening to The Joel Natale Show, Erie, Pennsylvania's daily podcast from TalkErie.com. Subscribe to our show on your favorite podcatcher and get involved by emailing joel@TalkErie.com.